thought that I would take this opportunity to really speak with all of you about a health systems perspective on sort of how we can use apps, wearables, and digital health to bring us into the future and really do, I think, hopefully address some of the topics that we were just talking about is, can there be a business case for how this can make sense for health systems? So I'll take a little bit of a different perspective and try to share that with you. Many of you have heard, and I saw how many physicians there were, so I would be very interested in your feedback, but many of you have heard of the Triple Aim. This came out in about 10 years ago from IHI, and this was saying this is what all healthcare really should be working towards: population health, reducing costs, and improving quality. So that's patient experience, that's how they do that. What we realized in healthcare is that we were missing something, a very important point, and you'll notice that on the side. It's the provider satisfaction. So it's how providers can use this. I think our first speaker mentioned one of the biggest challenges that you foresee will be the provider adoption for new technologies. I think that's something that we see too. So when we think about what should we be doing and how should we be directing our efforts, one of the things that we think about from a health system perspective is achieving this quadruple aim. So taking care of populations of patients, reducing costs, improving quality, and all the while making it easier for our physicians, which should be easy, right? Yeah. So some of the ways that we've been thinking about that, I think if you break this apart, we've proven that patients' engagement and involving patients in their care is very effective in both quality and population health. There are numerous studies that many of you all have probably written and read that prove that patients that are engaged in their care will improve their health just by the fact that they're engaged in their care. So how do we take that, though, and build upon it? So in terms of challenges that we have with that, if we can prove that engaging patients is valuable, which I think we have, then how do we engage them? There's thousands and thousands of health apps, there's thousands of devices. How do you decide what's effective, and how do you get those devices and those apps into patients' hands? That, as a health system, is something that's been very challenging for us. So one of the ways that we think about that is we introduce something that's called the O-Bar. So this is modeled after the Apple Genius Bar, actually. It's a place that's in our primary care centers that patients can come. You can see there's just apps sort of lined up. You can sit there and just play with things. You don't have to do anything. It's really supposed to be that Genius Bar concept where you can come and just try things out. We have the opportunity where you can put in your email address and they'll send you the apps that you're interested in. So you can say, I'm interested in a dietary app and something else, and we'll send that to your smartphone. So it really empowers the patients to be involved in their care and provides them an easy, friendly opportunity to do so. The other thing that we do at these locations is we also sell devices and wearables. So you can't buy a smartphone. It's not an actual Apple Genius Bar, but you can buy Fitbits, you can buy blood pressure cuffs, you can buy scales, you can buy things like that we can incorporate then into your care. The second thing that we do is we provide face-to-face instructions. So I'll talk a little bit about one of the programs that we have that we call the Hypertension Digital Medicine Program. The average age of patients in that program are 68 years old. Additionally, I should have mentioned this in the beginning, Oschner Health System is located in New Orleans, Louisiana, which is not necessarily known for being very active and healthy or tech-savvy, perhaps, but rather very fun and many other good qualities, but those would not be them. So this face-to-face instruction has been really important for our patients as well. It allows them to have a friendly face that can help them use their smartphone. One of the things that we talk about when we talk about the folks who work at the O-Bar is the most common question that they get asked is, what's my Apple password? So that's the biggest barrier for us to getting apps into patients' hands is they don't know that information off the top of their head. So then the best way to answer that question, by the way, is to say, can you call your son or daughter? And they will normally know it. But having someone facilitate that process has been very helpful for us. We can also do things like properly sized blood pressure cuffs, which is very critical to our program that I'll talk about. So if we know that patients prefer apps, and we know that we have patients with smartphone, I thought one of the things that was very surprising to me was the study that was done with 2,000 patients that both have both a chronic disease and a smartphone. The number of patients that are willing to take a medication, to fill a medication that's prescribed by their doctor for that chronic disease is only 2/3 of those patients. Those same patients, over 90% of them, are willing to use an app. So now we've sort of fixed this problem about how do we engage patients, how do we get this into their hands, we know it can improve health, how do we make it easy for our doctors? That quadruple aim is one that is very important to us. So we have tried a couple things that way, but one of them is instead of having to educate our physicians on blood pressure cuffs, on how to size them, on how to sell them, where to go and get them, or even to educate them on the apps that are out there, instead we give the physicians a prescription pad. We tell them this is what this service does for you, this is what the OBAR can help you do, and now you can just have these in your office, check off what you want the patient to go do. So I want them to have a wellness app. Then that patient can go to the OBAR and say, here, my doctor recommended that I come look here for a wellness app. So that's one thing that we're doing to help make physicians' lives a little bit easier. Another thing, and I don't think I could say anything without talking about our Innovation Oschner group, which is a group led by Dr. Milani, who's on this, really is to address the quadruple aim. We built the hypertension digital medicine program, and that's what I'll talk a little bit about. So that is based on this idea of, on the right-hand side of the screen, about how we can involve apps, wearables, with self-monitoring. Oh, maybe I'll get that, yeah. Self-monitoring and home monitoring, and how that enables something that we call specialized integrated practice units, or IPUs. So instead, the traditional healthcare model, where the patient comes to see the PCP and then that patient's really directed to separate places within the health system, instead, the way that we think about it in the future is building these IPUs that combine things like patient education, dietary, exercise. We have pharmacists on call. We have planners and just overall wellness representatives that participate in these IPUs, which we can enable because now we have data available to us, because those same patients can go buy wearables, get apps, provide that data. It's integrated into our EMR, and those IPUs can work in that area. This is the way we think about this, and this is what we base our digital medicine program on. So with that, there's also sort of continuous feedback. I guess I would say this feedback that's over here that goes directly to the patient, it doesn't bypass the provider, but the provider is no longer the person that's the facilitator of that or the holder of that information. We ask our providers to do so many different things. Now we can leverage these other clinicians and professionals to contact the patient directly. So one of the things that we do there is we provide these reports that go home monthly. They're sent electronically through the patient portal, but they're also sent on paper, which I think is something a little bit unique that we thought was really important, because this now engages patients' families or their friends in their care. So a spouse might not log into the portal for a patient, but they're very willing to see a piece of paper that's sitting on the kitchen counter and look at it and say, oh, you're doing really well with your blood pressure. So that's one of the things. And then just brief moment on outcomes is we have seen a very high control rate after 90 days. The average patient that's in the control groups, blood pressures are under 15% controlled. With the patients that are in this digital medicine program, we're seeing rates of 60, 65, 70% control rate for hypertension. I wanted to briefly mention how this also helps reduce costs, because that is the fourth part of the quadruple aim. And it's not necessarily as obvious, but we have a large capitated population, so anything that we can do to help prevent that patient from being seen in other scenarios, from having any events or something like that, is something that helps us reduce the cost. But it also provides, again, the patient experience and the provider work life. I think before I wanted to mention just this, some of the challenges to adoption, I know there are a lot of physicians here. There have been a lot of research recently about physician burnout and about how physicians are asked to do so many different things. The number one cause is too many bureaucratic tasks. If you think about some of the advancements that we all think about, meaningful use and MACRA and other governmental things, measuring quality that help try to achieve that quadruple aim, one of the downsides to that has been that we've been asking our providers to take on a lot of that work. So the providers have been doing all of that work so that we can measure quality and ensure outcomes and do all the things that we need to do. But that's been very difficult, which I think leads to physician physician adoption challenges that many of you have experienced. The second thing that I'll say is that this is an example, and this one's actually old, from Venture Scanner. This is just sort of a landscape of what's going on from a technology perspective in healthcare right now, and again, this one's a couple years old. If you can imagine that every one of these companies and initiatives is coming to a provider group like mine or like many of yours and is saying, we have all these ideas and here's the things we can do. How do we decide how that we can prioritize one over the other, and how do we make physicians' life easier in doing that? So it's just an overwhelming amount of things that are going on right now for our physicians. So that's why we've really focused on this IPU model, because it takes work off of the physician. So if you think about this in, if there are any cardiologists, the Coumadin clinic model, that's been going on for a while. You can refer your patients into the Coumadin clinic. Pharmacists there that specialize in that will now manage those patients for you. You're still involved in their care. You're still their primary care provider, or you're still their cardiologist. But you're not necessarily involved in the day-to-day changing of their medications. It's the same idea for chronic disease management, which is how we can use the data that we're getting real time to then make care decisions and help the patients, but without having to do that at the expense of what the provider's taking time to do. I think I'll close with the other thing that I think was a little bit unexpected for me was the importance of the O-bar. I can say I was probably excited about it from just kind of a coolness factor, but I didn't see it as critical to the success of the program. And it was unexpected that it is, because of all those things I mentioned, because of how we engage with the patients on a sort of person-to-person level about their health, but it's not necessarily in the context of their physician talking to them about it. That's been a really impactful for us, because I think there's a large barrier to entry without having something like that. So I think I can take a couple questions.
Great. Yeah, I thought that was fascinating. Thank you so much. I thought that your comment at the end really refers to the O-bar and the challenges of crossing the last mile, and sort of leaving with a here's what you do, and helping people to actually navigate their way onto the smartphone. One quick question that I did have was, a lot of these studies that sort of show benefits of approach A versus B, they tend not to be randomly selected. It tends to be, well, these are self-selected patients, and the combination of sort of enthusiastic patients who are excited about this and sort of self-identified, potentially with a little bit of Hawthorne effect. I don't know how you, do you worry about that?
I think we do, and actually the way that we approach it really is to involve the excited physicians first. So it might actually be on the physician side. We only started, not just pilot, but we just started the program with physicians who are very interested in participating. We've expanded it now. We have 200 physicians that participate in sending their patients into this program, sort of regardless of that. It's a recommendation from the physician, but the patient doesn't have to necessarily do it.
Very cool.
Hi, Rebecca Mitchell, Medical Director and Head of Clinical Product at Validic. I have a question related to a lot of the new data that you're bringing in front of the providers. So something that we're seeing a lot in the market is, let's take a specific example, like blood pressure and hypertension. An individual reading maybe once a week, clinicians absolutely know what to do with that, to the extent that they trust it. When we see patients that are taking blood pressure maybe 2 to 3 times per day, you're starting to see some really interesting morphologies and behaviors that nobody's used to seeing. Like we've worked with some of the best cardiologists, pharmacists in the country, and are very quickly getting to places where there is no literature on the proper course of treatment. There's no literature. They don't have any past experience on how to titrate a medication, how to advise around behavioral interventions. And I'm just curious if you've seen any of that being a blocker to uptake within your institution, and regardless sort of where you see some of that guidance coming from, because we're making decisions about whether or not we partner with some of these new AI, like big data companies, to offer that, or if that will be something that'll be rejected by the provider community.
Sure, that's a great point. I think one of the things that helped us is the champion for this project I mentioned is our Chief Transformation Officer, Dr. Milani. He's a cardiologist by training as well. So he was able to address some of those as to how you would manage hypertension. Obviously, we use evidence-based standards as well. We have probably 100, I think we average about 160 blood pressure readings in the 3 months that we look at for this study in particular, for patients that are enrolled in the program, compared to 2 or 3 from patients who aren't. So it really is having a lot more data, but then we did build some algorithms to to look at the standard deviation of what the readings are, and we do have a program that says if we get a very high reading, we automatically text the patient. So there's different sort of levels, but the first level is we automatically text the patient that says, your reading looked high, can you take it again? Can you sit down and take it again? So that happens. If it's very high, if it's over 2 standard deviations away, then we call the patient and talk to them, because we have sort of those real-time health coaches, clinicians that are monitoring the data on a real-time basis as well. So that's not in the middle of the night, but still during the day.
Another question, do you, while we're waiting for additional questions, do you have a systematic approach for your funnel for going from the thousands and thousands of potential apps you might recommend to the handful that you offer at the OBAR?
There is an approach. I can't say that it is entirely as systematic as one would maybe like it to be, but we do look at them. We have sort of a group of people that are curating the apps. It's not to say that it's a perfect process, but that's the process that we're using today.
Terrific. Well, let me see, any other questions? No. Okay, well, thank you so much. That was fascinating.